My name is Shelley Brown. Jessica Atkinson is also here with me tonight. We'll hear from her in a little bit. And we are hygiene educators. And tonight we have Jessica Woods with us. I'll introduce her here in just a little bit. And she works with a company called Blue Check Insights of Technologies. She recently came and did a guest speaking lecture for me on Friday. This has been the second time she's come to speak to my students about finding caries earlier, and that is part of our risk assessment. So I'll introduce her here in just a little bit. Okay, also, this is our disclaimer, just that, anything that you learn this evening, you have to do your own research and use your professional judgment, using that in your practice. So this evening, we're going to talk all about risk assessments and maybe a few things that they are missing and maybe some things that we might want to add in and just talk about which ones that we are using. So today we're talking about Caries risk assessments and what are these? They're the clinical process of establishing the probability that a patient might develop a new carious lesion or that the lesions that they already have might potentially grow over a period of time. And why do we have them? Helps us create personalized care, gives us clinical guidance on what things to recommend to the patient so we can lower this, helps us have better communication with our patients, helps build trust and motivates our patients. And then, the ADA and AAPD and Canberra came up with some, so it's evidence-based, and they've done a lot of research on these things. And then now, there's legal and ethical protections where we have a code for these things, and so it's become the standard of care to do caries risk assessments. And we have our students place the codes in, right? I'm hopeful that you guys are also doing that. If you are, you can let us know. If you're not, maybe it's time to think about, oh, actually, maybe we should start having them document that code if they're doing those health risk assessments. I'll say we probably added in Carrie's risk assessments. Maybe, let's see, when did I get my master's degree? Like, when did we do that? Just 2019?
It was 19.
About 2019, one of our clinical instructors, she did her master's degree on Caries risk assessments and made one and kind of adapted one. And so we use hers. And so that's when we started adding that in. And that's when we started seeing it more and more frequent, even though, the first ones came out a while ago. So with that, this was the karyogram back in 1976, where, they used the Caries experience and related diseases and frequency, diet, strep mutans, and they made these little pie charts when computers started to become kind of popular. And then they decided in like the, pre-90s that there was little focus on individualized risk of patients. We were just like, we see it, we're just going to treat it. We don't, how can we better prevent this? In the 90s, they showed research that caries is not evenly distributed. And then there was kind of more interest in, this risk factor terminology, and that kind of grew. And then 2002 to 2003, the Canberra was developed by the California Dental Association. 2007, that was published. I remember my instructor, Mr. Denhalter, Jess, he was talking all about Canberra, and I was like, I have no idea what this man's talking about. What's happening here? So there's a little bit of a disconnect for me as a provider and clinician. I didn't really know what risk assessment meant for a little while. And then now in the, 2010s and beyond, the ADA has one, the American Academy of Pediatric Dentistry. They have a type of form, and now it is the standard of care to do these caries risk assessments. So I would love to know, I don't have my chat box pulled up here, but I would love to know if you're using a specific form or if you have made one of your own. Jessica's going to show us the one that her school uses here in just a little bit, but I would love to hear, what you're using in your schools. And maybe even if you have a child version versus an adult version, we just have one that we're using. But as you can see here, this is the American Dental Association one. They have one that's for 0 to 6 and then 6 and beyond. And of course, we're gonna, mark the boxes. We have the students mark the boxes and they determine if they're low or high or whatever it might be. And then, of course, they use their best clinical judgment to kind of find some of those lines. This one is from the American Academy of Pediatric Dentistry. They have one for 0 to 5 and then 6 and up. And we're circling all the yeses. This is also the Canberra one. We're circling some of the yeses or check marking the boxes, and we kind of weigh and balance like where our patient lands. Some of them have, low, moderate, and high risk, and then some of them have that extreme risk. And we have the extreme risk on ours, and Jessica's going to show us this one here in a minute that also has an extreme risk, which I really like having that. So advancing Caries risk assessments, I do feel like, that's one advancement we should make is making sure that there is an extreme category on our Caries risk assessments, because it's kind of hidden on some of the other ones. So I'm interested to know if some of you have uh, that more extreme risk factor on yours as well. So I'm going to have Jessica explain hers that they're using at their school. They've kindly been willing to share that with us tonight. Here,
Here is our Canberra. And just like Camille, we do a series of risk assessments. So we have our cancer risk assessment, we have our caries risk assessment, and then we have our perio risk assessment. And each assessment is formatted similarly to what you see on the screen. And what we have here is an adapted Excel sheet. You can do it in Google, you can do it in whatever Sheets program that you enjoy using. And we adapted the Canberra aspects of all of the resources that Shelley just shared with you for our clinic itself. And so what you see here on the left hand of your screen is you see the list of questions that we ask our patient population, and it's a drop down box, and the student is it's either yes or no, and they drop down, and then it actually will auto populate the risk for you. So depending on what you answer yes and what you answer no to, then you get this little blue X on the risk assessment that will be assigned based on the answers that were provided. So this is how we apply it in our clinic in during their care plan and AdPi process. So we really like that it's an auto-populate because, I mean, math is an important skill. I don't want to like poo-poo on math. It's a really important skill, or how to, tally, or did they say yes to the right question to make them an extreme? And we just put that information at the back end of these sheets, and then it will auto-populate for our students. So that's what we do. And big round of applause for Kim Jensen, who's on this call, hopefully. And she created this, and we're so grateful.
yeah, thank you so much, Kim. Thanks, Jess. So, I think too, Jessica, that artificial intelligence will someday we'll have more of these questions incorporated into the health history, don't you think? And so the patients will almost like show up knowing their caries risk assessment. It will like give them a pre-assessment of their perio risk and their caries risk, maybe even before they get to us, because maybe the questions that we're asking them beforehand, or, these new systems are listening to us as we're with our patient, and they like create a synopsis of the whole appointment, and they can help us make that caries risk assessment. So the future is bright on implementing these and making them a little more streamlined. But there are some things that maybe are missing on our caries risk assessments. They're already pretty lengthy, but the ones that I came up with were demineralization, levels. There's a lot of different levels. Maybe we don't see salivary testing on some, testing the oral microbiome, diet, airway, social barriers, medications, sensory behavior, fluoride refusal, non-fluoride therapies, mental health. So there might be some other things on there that we might, that might be missing, that maybe we want to encourage students in some way to be thinking about using that clinical judgment, having those ideas in mind as well. The first one, though, that I want to start off with that maybe we're missing just a little bit, and this is the ADA caries risk assessment section that talks about, does your patient already have carious lesions, or do they have restorations within a certain number of months? So it also includes this first line, cavitated or non-cavitated incipient lesions. And I'll tell you right now, we are finding incipient lesions too late. We're finding them when we can see them as a white spot lesion, or radiographically, we can start to see an incipient caries, which we usually know once we start to see it, it's a lot bigger than it is clinically than we can see on the radiograph, right? And so this incipient portion is really important to our caries risk assessment. That's why I invited Jessica Woods on here tonight because I really want you guys to learn about what's called Blue Check. It helps us find caries earlier. It was something that I learned about when I became a mobile clinician. And I had the CareQuest minimally invasive guide, and I was placing silver fluorides and using curidons and things like that. And there was this dye that would dye the teeth and it would turn areas a certain color, and you knew those were areas that needed to be fortified. And I was like, where is this blue stuff? And it finally came out this year. And so I had invited Jessica to come on because she guest spoke for me on it, and she did it again for me recently. And then we tried it out on each other on the students, and we found several incipient lesions on them, which was really fascinating for them to really experience. But if we can find this earlier, it really makes all the difference. So I'm going to stop share and I'm going to have Jessica Woods come on and she'll share. But as she's coming on, let me read you her bio. She seeks to empower the dental industry to a bright future by inspiring clinicians to reignite careers. A 20-year veteran in the industry, she's a clinical product expert leader, thought leader, nonprofit practice owner in Las Vegas, and sought after mentor. Woods has spoken to thousands of dental professionals across the country, offering her unique experiences implementing minimally invasive and preventive programs that has led to product go-to market strategies from startups from Fortune 500 companies. She's going to Ohio this weekend, actually. She's teaching ITRs, and I'm like, I really want to be in your class. So someday I'll get there. She's affectionately known as the executive RDH, and she has scaled her way to the boardroom since graduation from West Coast University with a bachelor's of science in dental hygiene and master's degree in public health from A.T. Still University. She's been recognized and is one of the top 50 teledentistry leaders and hygienist of the year, and she won a Denobi Award this year. Yes, yes, I was there. That was fun. And she has a strong passion for introducing others to alternative career paths in dentistry and supporting them as they grow in the profession. And she established the Dental Public Health Collaborative, which offers postgraduate training and mentorship network for colleagues as they venture out of the traditional four walls of dentistry. So with that, Jessica, I'm going to have you come on and she's going to tell us about Blue Check and how to find these incipient lesions earlier, and then a little bit about her university program. And then we'll continue on with some extra ways to advance our caries risk assessment. Thanks, Jessica.
Thank you. Thank you all for having me today. Yeah, I'm Jessica Woods. I got the long version of my bio. So I'm here in Las Vegas, Nevada. And so just kind of to pick up where Shelley left off and talking about, the sensitivity of the detection tools that are currently standard of care. Really, they're lagging, and meaning that they're a lagging indicator where we're really analyzing the past. So there's a certain degree of disease that is present when we're able to identify. So like a radiographic presentation, typically, there's about 40 to 60% penetration through the enamel before it even shows up on a radiograph. That visual tactile exam can actually be invasive. If there's remineralization that's happening, there's a picture there, you can see that, there can be remineralization happening. And if we go through with an Explorer, we can actually disrupt that and spread the cariogenic bacteria. And then that like first visual cue is oftentimes a white spot. And that's usually what maybe triggers us to start to take action there. So where we're heading with new technologies and aids for caries detection will really help to bring us to a leading indicator where we're able to influence the future. And so those things look like being able to essentially identify biomarkers that play a key role in the caries process. And so that can be like shifts in pH, whether it's the shift in the pH of biofilm or saliva, and then also trying to identify pre-visible or subclinical demineralization before it even manifests into a white spot. So there's a couple of different products on the market that are available today. And kind of two classifications. These first three here, and I'll explain to you a little bit about how each of them work. These are actually disease indicators, meaning that there's actually porosity or demineralization present, and they're able to highlight that. This last one here is called CaviSense, and this is more of a risk indicator. So this tells you how this one works is it's a toothpick that you can use in between the teeth, and it has like litmus paper almost on it. I don't know what exactly they put on there, but you do a sucrose challenge. And so you have the patient chew and activate the biofilm, and then you can place it in between the teeth, and it'll tell you areas where there is acidic biofilm. So anytime there's biofilm that's below a pH of 5.5. Why this one is more of a risk indicator is because just because there is biofilm that is 5.5 doesn't necessarily mean that there's disease present because there could be, commensal bacteria, protective factors, buffering capabilities in the saliva, but it does let you and your patient know that there is areas that are at risk for development. These other three are actually disease indicators where they're able to help you visualize, demineralization that is present. So this first one here, this is called calcivis. And they all use a little bit, they have a little bit different mechanism of action. So this first one is calcivis. It uses a photoprotein. So similar like Botox, you reconstitute the photoprotein. You use this camera here. It's like an intraoral camera. You put the photoprotein, and as you press the button, it deposits the photoprotein and snaps a picture at the same time. And you can see there on the little computer, it has some software, and you can actually, it's capturing that free ion, that calcium ion release that's associated with demineralization. Then here in the middle, we have a product called LumiCare. It's a rinse. So the patient would rinse with it, and then you can use a curing light, and you go around the teeth, and all the areas that like illuminate green indicate that there's demineralization present. And then this product here is Blue Check. So this is a paint-on technology. So it's similar to like a disclosing agent where you would apply it on all of the teeth and think of it as demineralization disclosing rather than biofilm disclosing. We're going to talk a little bit more in depth about Blue Check. And here, just to give you an idea of the sensitivity, typically, for a white spot, a visual white spot, it's about 200 microns. That lesion is the depth of that lesion. For it to show up on a radiograph, it's about 150 microns. But with a product like Blue Check, we can actually detect a lesion at 30 microns. So it's about 8 times more sensitive. But however, we don't want it so sensitive that it just picks up the regular Riemann-Diemann balance that happens in the mouth. Typically, that's about 5 to 10 microns of change. So it helps us with our sensitivity and being able to identify those shifts in biomarkers much earlier than we have been in the past. And why that's important is because the earlier that we can get remineralization agents onto the tooth, the more effective that they're going to be. And also, the earlier we can encourage and modify, motivate behavior change as well. So the earlier that, there's a lot of research showing the earlier that you get the remineralization agent on the lesion, the more effective it's going to be. The closer we get to cavitation, the less effective those remineralization or agents are going to be. So this is really thought of as, the new frontier in our routine dental exam. It's very easy to do. You don't really need any additional equipment. So everything you would just have in your operatory already. You need something to clean the teeth. So it's great during a hygiene visit, after you polish, either with a Profi cup or with air polish. And then you apply it with either a brush or a microtip applicator. I prefer a brush, but I don't know, Shelly, you can say how you like to do it. I like a brush, but it doesn't come packaged with it because it is clinician's preference. And then you apply it to the teeth, and then you just need something to rinse with and then something to remove it. So it will go away on its own if you do nothing. It takes, a few hours, just the saliva will break it down. But if you want to remove it right away, you can use an SLS containing toothpaste, or if the patient has a contraindication to SLS, then you can use a little bit of hydrogen peroxide, just dip a microtip applicator and remove it there. It can be applied by any dental professional, so dental assistants can apply it too. So think of it like radiographs, the dental assistant, dental hygienist, they can take the radiographs, and then depending on the scope of practice within the state, the interpretation, follows in line with that, whether the, hygienist can do the dental hygiene diagnosis, or whether, the assessment needs to be done by the dentist. And then it does give you that straightforward detection. One thing I didn't include in here, but typically, how we're doing the visual inspection is by drying the teeth, noting chalkiness, changes in the enamel, which can be very difficult to do, and take a lot of time to do that on each and every tooth. So this really helps to give a straightforward detection of all the teeth. So again, the first step is just to make sure that the teeth are free of biofilm. So that way the product can come in contact with the enamel, and you apply it to all the teeth like so. It sits for 60 seconds, and then you have the patient rinse. So you can either do like an air water syringe rinse, or you can have them swish and spit for 10 seconds. And then you'll get the detection, and you'll want to record it. So whether you just jot it down in the chart where it is, ideally an intraoral photo might work best. Because remember, we are detecting subclinical things that we can't see with our naked eye. So we do want to keep record of what we've detected. The other reason is, blue check only detects active lesions. So if you may see like a white spot and you apply blue check and it doesn't bind there, that actually gives you an indication that that white spot is not active, it's arrested. And so blue check can be used as a monitoring tool as well to monitor how well your remineralization agents. And then also, if you have a white spot that's not active, you may not need to do anything but continue monitoring. So here's, just kind of a close-up of a before and after. So you can see clinically, you don't really see anything visually, but with blue check, it really helps to visualize that demineralization. The other thing to note is that the shade of blue also gives you some indication to your clinical decision making. So if you see like a lighter shade of blue, the darker the blue, the deeper the lesion. We haven't been able to exactly quantify, this shade of blue is, this lesion depth, but we do know that as the lesion progresses, that and gets closer to cavitation, the shade of blue gets darker. And so this can also help with your clinical decision making. Say you see really faint blue, maybe you're just going to do a fluoride varnish treatment or put them on a high fluoride toothpaste. Whereas if you're seeing something darker, you might want to do something targeted like Curadont or place a silver fluoride or something like that. And the other attribute of it is that it is objective. So, it kind of takes the subjectivity out of the detection with the clinicians. And, when you're working in an environment with a lot of students, it kind of helps to calibrate everyone and everyone calling the same thing. And then when you get into practice, if you're working in a multi-provider practice, some people might be conservative, some might be a little more aggressive. And so it can be a way to align everybody to, the same way of doing it. So how blue check works is, it's very different than a traditional Caries stain. If you're familiar, those are typically used in dentin, and it's a dye that attaches to exposed collagen, and it's to help during the restoration process. So blue check is used. The way that it works is it has a protein that has an affinity to hydroxyapatite, and there's also a linker and a dye. So the dye in this actually just gives the visual cue. It's not what's doing the work. It's this protein here. So when there is starting to have demineralization happen, this surface layer here starts to break down and become permeable, and the porosity is exposed. There is exposed hydroxyapatite crystals. And because this protein has an affinity there, it binds to those areas. And with the help of that dye, it gives you a visual cue of what's happening. So in a healthy enamel, this dense hydroxyapatite mineral, it's the hydroxyapatite mineral is dense on the outside, and so there's no porosity for the product to bind to. And again, you can use it to monitor, because once a lesion progresses, that surface layer becomes intact again, and so the blue check can't get in, there's no porosity again to bind to. So And I apologize, I can't see if there's any questions, but I'm happy to answer any questions. Sometimes there is around this. But I'm going to just talk briefly about the application I showed you already, but this is intended for dental professionals only. Basically, you just need, your vial of Blue Check. It comes in a small glass unit dose vial. So it's intended for one single patient use. You do need to provide the applicator. So whether it's a brush or microtip applicator, some way to remove the biofilm. So usually in the clinical setting, that's going to be with a prophy cup or air polishing toothpaste, and that's just to remove any residual Blue Check after the detection's done if you want to remove it, and then something to rinse. So pretty straightforward. I think I can kind of go through this quickly. We want to clean the teeth, then we apply for 60 seconds, have the patient rinse, and then we're going to detect and record. So really it helps you to know where to target your remineralization therapeutics. It's also a great patient education tool because sometimes we're trying to show them things on x-rays. Without a trained eye, it can be very difficult, but with something that's blue, they certainly know that that's not intended to be there. So it can be a great way to discuss the caries risk assessment, use it as part of it, and discuss with the patient. And then ongoing monitoring, think of it like probing this, like you establish your baseline, then you see how things are, identify changes. If things improve, can congratulate the patient. Or, if that lesion hasn't, improved, then maybe you want to switch to a different therapeutic or, layer your therapeutics, however you decide to move forward. And then you can just rinse very easily. You may notice that in some small grooves that the Blue Check might remain, if the toothbrush can't get into those areas, but it will go away on its own. So pretty good there. So here, the idea is that, if that white spot has really been your trigger to start deploying some of these therapeutics, now with the addition of an aid to be able to identify the subclinical, it really shifts everything over, and it just helps us to start the process earlier and to manage caries more like disease, chronic disease based, like where we're identifying, it's like blood work, you're able to see things before it actually manifests and start to do something about it and trigger those, behavior changes. I'm going to just share one of my cases with you. So hopefully this will just help bring everything together so you can see what it looks like in clinical practice and the clinical workflow. So
And
this was
Jessica, I know you're talking us through this case study, but the question is, where do we add this in? So I think you're going to talk about it in the case study. So somebody just posted a question about it. So
Yeah. So you would
continue on.
want it after, so ideally, like, if you're working more in a private practice setting, it would be after you polish the patient, we want all the biofilm. You can apply it, have it ready, and then, if the dentist, then have the dentist come in. Usually with who I work with, I let them know, oh, there is some detection, and just kind of have them give the blessing, and they do the assessment of it and how we're going to move forward. I mean, I work with, pretty collaborative, but different clinicians, but it's definitely going to be after you remove the biofilm. All right. So this was one of my patients. These x-rays are before I saw him. So he was 16 years old. He presented for like a cavity clearance for a second round of aligners. He went through some expansion. You can see here he had quite a few incipient lesions. I think he had about 8 or 9 incipient lesions interproximally. And really, they just chose to watch and wait. I think this is before Curodont came out, and the office didn't really use STF. So, um, just kind of watch and wait. They did a prophy, they did apply a couple sealants, but he was a high caries risk. So he came back 1 year later, and this is when I saw him. And so he, still had those lesions. They didn't go away on their own. They didn't remineralize on their own. Some of them even progressed a bit. And then at this time, we introduced Blue Check. And so we also, in conjunction with the radiographs, we did Blue Check. So we cleaned his teeth. We applied the Blue Check. We let it sit for 60 seconds, and then we rinsed it off. And then I'm going to show you a couple of the detections. So you can see here, this tooth, I mean, I don't know how the resolution is, but you can't really see anything. But then once we get over here, you can see on number 27, a pretty prominent detection there. Also this on the mesial 4, and then there was a couple of occlusal, so you can see them noted there. I just kind of pulled the pictures that you could see the best here. So what we did for this patient is in the aesthetic zone on the anteriors, we did place Curodont, so the self-assembling peptide P11-4. So we placed that there and then interproximally placed SDF. And then I finished him off with an application of povidone iodine. And then I had him close for 10 seconds and then open again. And then I put an application of fluoride varnish. Since he was an extreme caries risk, I sent him home with the povidone iodine as well, because I don't know how familiar you are with povidone iodine, but it does target the cariogenic bacteria. It also makes the plaque less sticky. And so it can be a great tool, pretty like easy compliance tool for those, moderate or high caries or extreme caries risk patients, and they can do it at home. Another thing I do want to mention, because this question always comes up quite a bit, is can you apply the remineralization agent right on top of the blue check application? And yes, you can. So this was a poster that we released at, I think it was at Orca this last year. And so we did test a lot of the therapeutics. And what we found is that there was no difference in the uptake, whether you removed blue check first or just applied the therapeutic right over blue check. With something like Curodont, you typically do like an etch step. And so the itch itself denatures the blue check. But then like SDF, I just placed it right over top of that. So that just in case you had that question. So here's kind of what it looked like, a little bit about the economics. So with, just the radiographs alone, like that standard of care, there were 8 incipient lesions. With that, I would have placed 8 sites of SDF. We use pretty conservative reimbursement rates. Things might look different depending on where you are. We just use the Medicaid rates here in Nevada. And here, you can see what was done. And then with the addition of blue check, we identified more areas of demineralization. So we were able to actually treat, with Curodont. We placed additional sealants. I didn't show that in the photos, but I did place some glass ionomer sealants on the teeth that had detection. And so you can see too that it also, adds value to the patient, but also can be very easy things to do chair side that really, help elevate the hygienist to play a more active role in the caries management process, not just in the risk assessment, but actually managing the disease. So let's take a look at what we did here. So this was a 1-month follow-up. Not the best pictures because the mom sent me this with a cell phone, but you can see what I like is that, when you looked back at, I don't think I called it out very well, but look at this lesion here on the mesial of number 4. You can actually see the white spot there, and you can see that blue check binds to that. So that lets you know that's an active white spot, and help with your clinical decision making. If that wasn't binding, I may have just left it alone and let, the fluoride varnish and the povidone iodine hopefully maintain that from, being active again. So here you can see I placed SDF, and so you can see that staining happening. So I thought that was just interesting because, some people are like, how do we know that blue check, binding? It's like it did bind there, and then it stained with the SDF, where we know only active demineralization stains as well. Here's a little bit better of a picture. You can see at the 2-month follow-up, and then here was where we placed Curodont. So you can see at 2.5 months, already getting a good amount of remineralization or regeneration, whether it's coming from the fluoride or the peptide scaffolding there. And then here is the full treatment time, which I think is about, 6 months you would want to give for the full. And then you can see pretty good. That's where we started. And then this was at nearly 6 months trying to catch him on, school break. So it wasn't quite 6 months. If you look really closely, there's like a tiny little fleck there for me. I don't know if that's enough to justify, reapplying Curodont. I would probably just do another application of fluoride varnish there and, have him continue on to using the povidone iodine. So there's just kind of the sequence of events that happened. And so you can understand how we used it as detection and used it as monitoring too. All right. So the last thing I just wanted to present, and sorry, hopefully I didn't take too much time. Shelly, I'm trying to go fast. Okay,
You're
good.
doing great.
Um, is we do have a university partnership program. So as she mentioned, Incisive Technologies is the company that makes Blue Check. It's an Australian-based company. The technology actually came out of the University of Melbourne in Australia. And so, and our mission is to equip oral health professionals with the tools they need to address the global challenge of tooth decay. And so that's a little bit about our company. And, we are always looking for ways to partner with, different universities and schools on, their research efforts. And so we do have a program where, if you had any students or you wanted to do any research in, in kind of the school-based setting, we would be happy to partner with you and help to provide whatever you would need for your product needs. So it's just something to keep in mind, as your students start to think about their table clinics and such. We have come up with this list of just some ideas of things that like we would find interesting and might be small scale studies that could be done in a school year. But certainly it's not limited to that. We welcome any creativity as well. And so I'm happy to provide this flyer to Shelly and she could send it out to all of you. So if that's something you're interested in. And then again, I'm happy to do presentations either for your faculty or your school or both to learn a little bit about how these tools can enhance the learning experience for your students. I think there's a way for you guys to opt in if you're okay with me sending you a follow-up because happy to send out more information about how you can schedule, those demos and get samples for your students. But here is a QR code if you'd like as well. I'm keeping it in there in case anybody watches the recording too, if they want to reach out and you can just fill that out. But that's all I have for you tonight. That's my information. So I'm happy to answer any questions anyone has or connect with you offline. That's mine. Or if you want to follow me on Instagram too, I'm executive_RDH. That's a good way. My email gets really bogged down. So sometimes I'm a little quicker to answer like small little questions on social media. So,
Jessica, we did have a few questions.
okay.
One was, how do you decide between SDF and Curodont?
Okay, so a couple things usually in my clinical decision making, but please chime in, Shelley, because I know you use both as well. So Curodont is only indicated for non-cavitated lesions. So that's first and foremost. So really going to be white spots or these subclinical lesions. SDF can be used on both non-cavitated and cavitated lesions. So if it's getting closer, I see it radiographically. To me, that's getting closer to cavitation, and I would likely place SDF. However, SDF does have the staining concern with it on those active lesions. And so if I'm working in the aesthetic zone, I'm likely not going to place SDF there. Since his a lot were in between his teeth, you could, you're likely not going to see that staining that happen. I've done it on myself too. He was an ortho, so right there between 4 and 5, there was some space, and that's why we were able to kind of see what was going on. But it's since closed pretty well, and you don't see that staining because I placed it other places where I couldn't capture a picture. So those are kind of the main things that I use for my clinical decision making. And you can see I used a combination of the two because of that.
And I think SDF is, it's a lot more inexpensive than a Curodont. A Curodont's going to be like $100, where SDF, it costs us $1 a drop. So
Definitely.
what was your Medicaid fee on that, Jessica? I forgot.
So I think so for Blue Check, they cover it at $6 an application.
Mhm.
So it's D0600. I think you had it in one of your slides with the code. I think we get reimbursed for like $35 a site for SDF and Curodont nothing
Oh,
yet.
seriously.
So
Okay. So
yeah,
it might be
but
coverage.
yeah, so it could be that too. Definitely, the Curodon is a little more cost prohibitive as well. So one applicator of Curodon, I think, costs around $30, and you can do about 3 lesions. So it's about $10 a lesion, whereas with SDF, it's about $1 a drop, and you can do about 5 lesions-ish with a drop. So just to give some comparison there. So yeah, it kind of depends, on the setting. In public health, I'm using SDF a lot. Thankfully, Curodont does donate some product to me, so I use it in those anterior cases when I can.
Hmm.
But
And
I
then
mean,
the
SDF is what I'd go to battle with for
yeah,
sure.
agreed. And yeah, the silver diamine fluoride, there's some differences there. Also the question was asked, like, do you bring the patient back? But I do this at the end of the appointment once all the biofilm is removed. Yeah, right before the dentist comes in for the exam. Very important that all the biofilm is gone. So that's when that would be done. And Jessica, also, before you stop sharing, will you go back to your slide where you see all the floss in between the teeth
Oh
for
yeah.
just a second? I love this picture so much because this is the way of the future. Okay. Silver diamine fluorides can prevent caries, right? And if you floss it in between there for a minute, you put the floss in, you put a little dab of silver diamine fluoride on there and you pull that in for 1 minute and then it works. Okay, it's remineralizing that tooth and building that tooth structure back off up. So just like we're doing sealants for patients nowadays, we will preventively if they're high caries risk on, especially like teens, anybody who's high caries risk, we can preventively floss SDF between the teeth and prevent caries from occurring in
And
a
yeah, and on
high risk
occlusal
patient.
surfaces, really on any high risk
Yes.
surface, because remember, SDF will not sustain sound enamel or dentin. It's only going
Right.
to be, so there is some, you don't know. There could be subclinical
Risk.
demineralization. You could, stain a little.
Yes.
In its own right, SDF is a caries detection tool too.
Yes.
So yeah, I did that. I have a 5-year-old daughter and she had like airway issues and she was high caries risk and she was just too young to try to get sealants on her primary teeth. And so I I was able to like just do one quadrant at a time. I put a little SDF on there, then covered it with fluoride varnish. And I mean, so far she's been pretty good. But
Yeah. I
yeah,
love that.
do it
Yeah, so
preventively.
this is something interesting, new and up and coming in dentistry where we're using SDF more preventively. And our clinic hasn't added SDF in yet, mainly because of the stain. And I'm wondering where you guys are at on using SDF in your clinics as well. Jessica says that she uses it, Jessica Atkinson, in her clinic, but I have 60 students, and so we are worried a little bit more about stain. So we haven't incorporated it in, but I bring it into the classroom. There's just always a lot of different ways to incorporate all these different products. Like Blue Check, currently we're in the classroom. It would be so amazing if we could do it in the clinic, but we do it in the classroom. We do go out in the clinic for a little bit and place it on each other. But there's a lot of these things we want to incorporate, and sometimes we just have to, find out creative ways to do that. Because I do know that there's like, CODA requires you to have certain peat process evaluations when you're doing some of these things, and so sometimes it's a little bit harder to incorporate some, but still introducing these, I think, is very, very important. So thank you so much, Jessica. If you have any other questions for her, you can chat with her in the chat box over there. But we're gonna go right till 7:30, and then at 7:30, I'm gonna post a link that will give you a little form to fill out for your CE credit this evening. So I'm gonna go through this next section pretty quickly. And just so that you can kind of get the gist of what are some of the things that are out there that you might want to incorporate in. Also, let's back up just a second because we're talking about Caries risk assessments, right? What assessment do I choose? And they recommend that the ideal one is evidence-based, inexpensive, and easy to use in the process of care for the patient. So something that's quick. There's a question, are they accurate? They showed sensitivity of 84% and specificity of 63% in one study, and then it was kind of opposite in another for those who are under 6. But 6 and up showed that it did have the ability to predict caries risk. So kind of interesting information there. 42% reported they rarely or never use a caries risk assessment due to time and maybe knowledge of how to implement it. Sometimes if we don't learn it in school, it's hard to be like, I'm going to do it, right? So we're having students come out with this new great knowledge, maybe making it more simple. This is one from Elevate Oral Care, and it has, it's a patient education form at the same time. You can actually request one of these and they'll give these to your students. Helps them with patient education to know if your patient is low, moderate, or high. And you could incorporate something like this into clinic, something that's very simple, a great simple way to start. So what do we do now that we know the risk? Of course, our students inform the patient, they educate, and we're going to do in-office treatments and at-home treatments. So let's talk about some of those and how we modify that risk first in the operatory. So every one of our Caries risk assessments, they have recommendations associated with those on what to do in different scenarios. This is the one from Darby Walsh. So in our what can we do as clinicians? And I'll tell you right now, when I started like my mobile practice, I was doing fluoride varnish. I was like, okay, this is what I have. I have fluoride varnish. I'm gonna scale. I'm gonna do my periodontal therapy, my prophy, my patients, and do a fluoride treatment. And I learned really quickly that these patients in my mobile clinic, they are so high caries risk, and they can't make it to a dentist. So I thought, Shelly, how can you better prevent caries in these patients because they cannot literally go see a dentist and they cannot brush their teeth and nobody's helping them. And that's where I realized, man, there's so many other great things that I'm missing in a whole remineralization program. In hygiene school, we're so focused on instrumentation, instrumentation, instrumentation. We're taking a board on how to remove calculus and we're so focused on training on that, and that's important. But we forget we have this whole opportunity to remineralize teeth. And, sometimes we're just putting the fluoride varnish on at the end and that's about it. But there's some other great things that we can do. So this is the one from Darby Walsh. You're probably having students place sealants, varnishes at the end of the appointment. But some things that are missing as it comes to in-office treatments we're going to talk about some silver fluorides and Curodont. Um, so Curodont has a really high rate of remineralization. As she mentioned, it's a P11,4 peptide. Anytime you see a white spot lesion or a dentist says, we're going to watch that, that means it's time to act. We no longer watch. Okay, that's another thing. As a hygienist, we treat. If we hear the word watch, we should be treating. We should not be waiting. So we see this white spot lesion. You see it here 2 years later after I've placed it on, and we get remineralization with that. Sometimes you get a little bit of a color change, but you're essentially regrowing enamel structure, which is super exciting. So bringing this into the classroom or bring it into the clinic would be super exciting. I'm wondering if anybody here actually has a process evaluation where the students are doing Curodont in the clinic. I would love to know. In the chat box, maybe mention. Some of you I see are bringing in the silver fluorides, which I love so much. That's amazing. Jessica mentioned like sometimes you accidentally stain some extra areas. So we treated this lesion here, and it spread down to that class 5 area. I did not know there was caries on that one. So of course you always have to get consent from the patient. So you might have staining in some other areas, but then that area is now fortified and preventing caries. So that's awesome. Oh, sorry. Um, we also know about SDF that it penetrates the dentinal tubules, creates an alkaline environment, forms bonds with phosphate and calcium to make a stronger tooth structure, stimulates tertiary dentin, which we love, and inhibits those MMP gelatinase 9s, which are responsible for demineralization. And with that, it prevents caries and remineralizes caries. You can see here in this image that these little microwires that are orange go down into those dentinal tubules, also creates what's called a zombie effect, which what happens is as they're still down in the dentinal tubules, when bacteria comes along, it essentially zaps that bacteria that came along. So there's no biofilm that then builds up in the area that continues to demineralize. It's not a one and done treatment. Usually, if they're high caries risk, I am doing a 2-week follow-up. And then for my mobile patients, I'm placing it every 3 months on these teeth because they're not getting their teeth brushed at all. Obviously, that might be different for a private practice and in school settings, but this is one of my patients where you can see the before and after. She had a stroke. She still could not brush her teeth, but you can see there's no biofilm there. Also, the gingival tissues look great. I mean, I did periodontal therapy on these areas too, but you can see that there's no biofilm because that silver is working down in there to continually repel that and not build up and cause periodontal diseases at the same time caries. So it's really an amazing product that we don't quite use enough, and it's up and coming in dentistry, right? Here's an image. They didn't do any scaling. They just did SDF. Here's a before and after, and you can see how the tissues responded Hopefully, we don't have this in our dental clinics, but if you're treating patients and you get to go out mobily and maybe a patient really can't open their mouth well and your student really just can't do a periodontal therapy for whatever reason that day, you can paint SDF around some of those margins and help repel that biofilm until we can get a more definitive treatment done. Reminder, it does not stain sound tooth structure. You don't always know if it's sound, but this is a before and 1 month after where there's no dark areas, but it was a sensitive tooth. There's a lot of different kinds and types of SDF that are out there available to us nowadays, and you'll have to do your own research and decide what's going to be best for your practice. But they are amazing products. I will say that the nano silver sodium fluoride just recently came out. I haven't had as great of success with remineralization with that one, more for hypersensitivity versus caries arrest, but that might be something that you start with in your clinic if you are worried about the stain. Great for hypersensitivity. As we mentioned, there's one company in Florida, they're a school-based program, and instead of sealants, they completely shifted over to doing SDF on occlusal surfaces because of this study that was done that showed that it prevented caries 81%, similar to rates to sealants over a 2-year period of time, which I thought was interesting. And we always place the fluoride varnish over SDF because it does get greater amount of remineralization, a tiny few points, but we'll take any points we can get, right? Jessica showed you a picture earlier that showed the teeth that were like more yellow. And that was povidone iodine. And the only company who sells this as a, let me just turn that down. Sorry about that. Only company who sells this is Elevate Oral Care. They have an FDA approved version. The risk sorry the CareQuest guide says you can actually just use 8 drops of over-the-counter povidone iodine, but if you want something more, FDA approved, this is it. It does not turn the teeth yellow. It will also prepare the tooth for fluoride, so if you use them together, you get about 70% caries prevention rate. You put it on the teeth, you don't rinse for 10 minutes. And if the patient has high caries risk, they're using this once a month. You can do it right before you do a fluoride varnish and then send them home with directions on how to do it monthly. Every other month for moderate patients, and it's not needed for those who have slight. Essentially, it's going to work on the strep mutans, the process that they use to build biofilms. And if they can't build biofilms, then they don't release the acid and cause the caries. So that's why it's being used more and more in dentistry. And I use it on all of my patients, and I have them and their caregivers use it on them monthly at home. Contraindications are listed here, though. So if there's wounds or thyroid conditions, you want to make sure you're paying attention to those. Some of the at-home treatments that we can recommend to patients, of course, our caries risk assessments talk about doing fluoride toothpastes and rinses and baking soda at home if there's extreme caries risk happening. But you could also include a probiotic. They're showing more and more that helping the commensal bacteria is important. If we give probiotics, which I have my patients take probiotics after they eat because they can't brush their teeth. It does help reduce periodontal diseases and caries. There's, of course, xylitol. They want, what is it, 5 grams 5 times a day if they can tolerate something like that. Some of my patients have GI problems and have a hard time with the xylitol, so the probiotics are helpful. Arginine to help with the pH. So after they eat, they can use something with arginine, which is kind of making a comeback, right? It has that help with the pH, bringing that pH back up. I personally love these basic bites. And we just did a caries class with my students, and I brought the basic bites in for them to try, and they loved that. So kind of a fun way to, incorporate some of those products into the classroom. There used to be a gum. Has anybody ever bought the sodium bicarbonate gum? It was really gross. I can't find it now. It was from Arm& Hammer. So I did find this gum reflux relief. I'm not sure much about it or if it has any studies with it, but there is, sodium bicarbonate. You can do 1 cup of water and 1 teaspoon of sodium bicarbonate for those who have extreme. When I was barfing every day when I had my last baby, I got some caries and I was trying to do the sodium bicarbonate, but it tasted really terrible and then I would barf again. So I was like, oh my goodness, I need something different to manage my pH, but this is what we have for now available. Also, we don't look at this too much, but are we looking at vitamin D in our patients? No, we're not currently doing that, but I think someday we will be more collaborative working with physicians and saying, hey, what are the vitamin D levels? Because if the teeth are developing with the right amounts of vitamin D, then we get 50% less caries on those who have proper vitamin D levels. And I don't think we're looking at that quite enough in dentistry, how the teeth are developing, other than saying, chew a fluoride tablet, which is under kind of under scrutiny right now. October 2025, all fluoridation tablets may get banned. We'll see what happens, but are we using this in our having our students, not our students write prescriptions, but the dentists write prescriptions as our students are finding out what the water levels are in the area. So we'll see what happens there. There's also MI paste. We actually have this one on our caries risk assessment. I'm wondering if anybody else is using this. Some love it and some don't love it. Some say that MI paste does not outperform standard fluoride treatments. Maybe if a patient doesn't like fluoride, maybe this might be a good option. The ADA did come out and say within this study in 2018 that they recommended against the use of it, but we still have it on ours because, they still make it and still some love it. So I'm wondering if anybody else has MI paste still in their practice and they're having patients use that. At home fluoride trays, if they're at extreme risk, if they've ever had, cancer therapies, especially head and neck radiation, they should be doing a fluoride at home tray for life with a gel, leaving it on for 10 minutes, no eating or drinking 30 minutes afterwards. We have our students make a reservoir tray, but we don't necessarily have them make it for patients who are high risk with head and neck radiation, which I would love to be able to bring that in someday. Mostly we're just educating in the classroom about it. And then recommendations for dry mouth products. There's a new one that just came out, Aquara, which is a prescription one that's more lipid based. This tool on the upper right hand side is like an electric tool that stimulates the saliva to come out of the glands. And so looking more if they have that extreme caries risk, some of those salivary replacements as well. So, the big question is, are caries risk assessment out of date? No, by no means. It's up and coming, it's exciting. But of course, maybe it shouldn't be used as a rigid predictor. Maybe just because they have high risk, obviously, if we can lower that risk, it might not always mean that they get a cavity. It should be paired, of course, with clinical judgment and an individualized care plan for patients. And the focus is shifting from risk prediction to active caries management and prevention. So, which is really exciting. How will you use some of these products that we've talked about tonight? Maybe just creating more awareness in your program, having guest speakers, having in-class activities with these different products. You could have the students do the presentations on them. You could choose to incorporate them into clinic because you know how it goes. When they do something in school, they're going to take it out into the real world, which is really exciting. And so we want to prepare them to be, the best clinicians that they can.